Thank you so much, Northwell Health, for inviting me to have this conversation with one of the leading innovators of our time when it comes to technology. Vinod Khosla, thank you so much for joining us. Now, of course, the founder and chief of Khosla Ventures, but before that, for folks who may not have been around, back at the dawn of the internet, or at least when it became more popular, you were also the co-founder of Sun Microsystems. And I'd like to start there, because you foresaw where things could go back when you were building the pipes of the systems that we take for granted now. And since then, you've been looking at all sorts of things, and you've been looking at all sorts of different parts of healthcare. Where do you think we are now in terms of moving forward and really integrating digital health and health technology and AI?
Well, I've been doing innovation for over 40 years, as you mentioned, since the beginning of Sun. I'm very excited because I think in the next 15 years, we'll see more innovation than we've seen in the last 40. So to imagine what 2037 might be like, you have to go back to 1980 or something to really understand how much change we are likely to see. So that is very exciting. And one of the reasons that's true is there's new vectors of innovation in all aspects of healthcare. So software is being used in innovation, but to me, that's sort of par for the course. AI is going to play a very large role. Robotics and automation will play a large role. The amount of measurement and we can do and the parallelization of measurement we can do will be disruptive in many, many things we do. And so whether you're talking about digital health, which is providing remote services or more digital services, whether you're talking testing blood tests or genomic tests or RNA tests, or you're talking about discovery of new therapeutics, these vectors of innovation will apply to all of them in a way that's hard for people to imagine. I like to say today what we have is the practice of medicine based on a lot of prior history and experience. In the next 15 years, we will see change to the science of medicine. And we don't really do the science of medicine today, and we can go into it. Some people will debate me. But the simplest example of it, today we mostly do symptom-based medicine. You know you have heart disease mostly when you have a heart attack, not 30 years earlier when the disease started. You know you have various chronic diseases 30 years after they started, whether it's Alzheimer's or Parkinson's. And I think all of this symptom-based medicine and diagnosis will change.
That is something that is certainly one thing that could help health and help prevention. But, you know, when I talk to leaders of health systems, you know, I sort of say to them, you know, we've been talking about being able to use artificial intelligence for the longest time. We've been talking about, you know, we talked about telehealth for 10 years, and it wasn't until we had a crisis when people could actually get reimbursed for using telehealth that we really saw the use case, and it really became much more ubiquitous.
So clearly, certain business models are enabled or disabled or discouraged by various kinds of billing mechanisms. It's the revenue is the lifeblood of healthcare. And whenever we talk about disrupting healthcare, it implies disrupting revenue structures. And it's not odd that, you know, a primary care visit that might cost $150 to $300 per visit, when it goes to $30 to $50 with telehealth, and telehealth is not technology in my view, it's putting doctors on a Zoom. it is disruptive to people's revenue structures, and if you can't bill for it, people don't adapt it. But when the differences become so disruptive, it's very hard to hold back. And most healthcare systems aren't providing for that today or thinking about it. I think the cost of primary care visit this decade should decline to between $1 to $5 per visit. Now, that
in terms of reimbursement or just a copay?
The cost of primary care, the total cost. Forget reimbursement, forget copay. This is well below the cost of copay today. If we use the right kind of remote medicine, and it's typically AI-driven, chat-based medicine. Now, it wouldn't be accepted for billing purposes because you can't bill it at $300, and certain organizations will resist. But if you change the destination, the definition of primary care from what is today's primary care or urgent care mostly to a much broader definition where your hypertension is managed in primary care, where your diabetes is managed in primary care, you will see that take over and affect the total cost of care downstream. So take somebody like an Oak Street. Their cost of primary care is probably $100 per member per month versus $20 to $25 for other payers. But what is the benefit to Oak Street? Other costs drop. So when you start taking risk and verticalized risk to the payer, or take responsibility, Medicare Advantage is a good example. These kinds of technologies that are cost-saving and radical can be introduced. Clearly, an order of magnitude reduction in the cost of primary care is possible below even today's urgent care remote telemedicine, which to me is really not technology, and it's not the right way to approach it because you don't get the same physician session after session. You don't have continuity of care. They don't take care of a lot of things that are critical to healthcare, like gaps in care, continuity of care, knowing what your record has done, medical record has done for the last 5 years. AI can summarize that in an instant and include it in a chat with a patient. It could literally ask a patient, 5 years ago you had this problem, are you still having it, or does it ever repeat? That's not possible in telemedicine. It's not even possible in today's individually built primary care sessions because you need to reduce the time of a session to 5 minutes or less. All that will change dramatically. But business models will have to adapt, and institutions will have to learn how to really be innovative.
You know, one of the things...
I do believe most institutions do this innovation thing very, very poorly and have to change the structure because their practitioners' workflow has to change very dramatically.
And that is one of the things that's difficult. And we talk about, I noticed that a lot of your investments are looking at that preventive, being able to get those baseline numbers on someone someday to be able to actually leverage your genomics to predict where you might need help or what kind of drug might actually help you, which sounds so incredible. It's sort of like the Jetsons growing up, watching that and seeing, those flying cars. It's like the flying cars of healthcare. But at the same time, we continue to overload our clinicians with so much data and so much that they have to do. How can we get that data to make sense and have them still be able to be practitioners and be paid for their work?
And this is a fundamental mistake we make. We collect data for humans to read, and that practice has to stop. Genomic data, when it costs $20, it will in the next 5 years to sequence the whole genome or get the full transcriptomics, what is every gene doing this moment? And how is it affected with a certain drug or a certain food you eat? Physicians can't be expected to look at 2.5 million data points. Just your microbiome test that a company like Viome does creates 2.5 million data points per stool sample. It's unreasonable to ask any human to look at it. So we have to have AI do that looking and the recommendations. So Viome will say, these are your superfoods and these are foods to avoid. Avoid the almonds because your oxalic acid is too high. Take more cashews. At that level of detail, and say, and we're doing this today. An onion doesn't have 3 ingredients. The FDA only has 100, 150 ingredients in its nutrition list. In fact, there's 28,000 ingredients every food should be characterized in. We are trying to do it. The 2,000 ingredients in onions or garlic activate or deactivate certain genes or gene networks. That's too much complexity for human beings. But you could imagine drinking a tea that reduces your IBD symptoms all in the next 10 years if we stop trying to give this data to humans to interpret, and they become more coaches, not diagnosticians in this process. So a very different workflow, very radical workflow, but it is the only way to both dramatically increase the quality of care and make it consistent across patients and providers, which doctor you get, and to make it much cheaper at the same time. So I do think the cost of care can go down in multiples if we take this approach, while improving quality and increasing consistency. I joked today that the physician you get is the diagnosis or the prescription you get, not the disease you have. When I had to have knee surgery, I had 3 different physicians look at the MRIs, and they prescribed 3 different things. One prescribed surgery, one prescribed don't do anything, and the third was try it in 6 months. And this is for a mechanical thing like a ACL tear. So the doctor you get shouldn't diagnose the disease, be the prescription you get. It should be based on consistent medical standards.
And, one of the things you keep talking about bringing the cost down, but it seems, I know over the last 10 years, I remember reading that RAND study that said once we got digitized, once we did, more digital things, we would bring out $100 billion or $75 billion, I think it was at the time, out of the system. And we've gone over the last 10 years from a $3 trillion health system to a $4 trillion health system. So we keep adding technology, we keep adding all these new things, and yet we've added value-based care, and yet we're spending more and more. So I have a hard time seeing how we bring the cost down.
So this is a problem with technology. Over the last decade or two, technology has generally escalated the cost of care. Fancier care, more tests, proton beam accelerators in every hospital system are trying to get as marketing advantages. We talk about value-based care. What percentage of the population is under value-based care? Who has an incentive to reduce the cost of care? Reducing the cost of care is reducing the revenue of health systems. So the only way it works, if you increase profitability while reducing revenue, which means dramatically bending the cost curve. One of the biggest factors, for example, AI could replace a lot of the expertise of medical practitioners, whether it's an oncologist or a primary care physician. Now, that won't be accepted by today's physicians unless they can increase their panel size from 2,000 patients they monitor to 10,000.
Oh.
Right?
I have a friend who's retiring because she says, I love my 2,000 patients, but that's a lot.
It is a lot, unless they only have to look at the exceptions, and AI is doing most of the recommendation. So we have a physical therapy company called Sword Health. AI does the physical therapy at home with patients. Well, what does the physical therapist do? They monitor the progress of the therapy as reported by the AI. Your knees bending to 120 degrees, not 150 degrees yet. And they change the therapy plan. So there is a large role for humans, but it's an oversight rule, building therapy plans and all that, not taking long time to sort of do 1 hour of physical therapy. And this is live today. Dramatically reduces the cost of care, dramatically increases compliance. Last Christmas Day, 50% of post-operative patients doing physical therapy did physical therapy on Christmas Day. You can't get that kind of compliance, and it clearly affects outcomes if you don't do physical therapy after a knee surgery or a shoulder surgery. So I do think the way of thinking about it is wrong and has to change dramatically if we're going to both reduce care and improve quality. 80% of primary care visits can be handled without touching the physician. But if their reimbursement depends on it, they will touch the patient, and then they can't increase panel sizes or reduce the cost of care or make it more comprehensive.
So but, there are times when you really do want that in-person.
Absolutely.
You need that touch. And there are things that you're going to find through that touch, talking to someone, whether it's mental health issues that may not pop up when you're just doing a very quick telehealth.
Oh, absolutely. So things should be triaged to the higher skill level of expertise. Yeah, I can do some things, but it should know when to triage up to a human, whether it's a specialist or not. And I think that will happen. So humans will have a role. They'll do 20% of the work that they do now and no paperwork, which is a big part of their workload, which is why large patient panels, they'll produce all the reports, all the billing, all those details. But the human will be in charge of coaching and guiding the patient through their patient journey. Absolutely. So the role of AI is often misinterpreted.
So as we wrap up here, do you think we're going to be in a very different place 15 years from now? Tell me what you see 15 years from now. How will we have bent the cost curve? How will it be different to go and get healthcare?
So practicing system like health provider, the single most important physician will be the primary care physician. Today, the specialist is the most important provider. The specialist expertise, whether they're a cardiologist or an oncologist, will be embedded in the AI, and the primary care physician will be the guide for the patient. That's a radical inversion of which is the most important doctor in the health system, who's the highest paid doctor. Today, it's not the primary care physician. They will be the most important. They will be the only source of integration.
But even for treating something like cancer, you need a specialist for that. And not every specialist knows every cancer.
That is the reason AI will know all the cancers, will know the last 5,000 publications on that cancer, will know all the gene mutations that are affecting that cancer, and what will or will not happen. But that cancer has to be integrated with cardiac disease the patient may also have, and diabetes and hypertension the patient may have. That complexity and that coordination will be done assisted by AI using the primary care physician, and the AI will know when it doesn't know about some new phenomena in cancer where they actually consult an expert. So most cancer patients don't get a tumor board today. It is a shame they don't get a tumor board. They will get an AI tumor board. And they will talk to their primary care physician about all the other conditions the patient has, and they will know when to escalate to a special expertise. So Fred Hutchinson or Memorial Sloan Kettering will get their role as specialists, but covering a lot more patients than they can serve today.
From your lips, I certainly would love to see a shakeup like that. And I think, and if it can make it easier for physicians, or at least more fulfilling for physicians to do their jobs, I think that is the hope that we have for innovation right now.
So Bertha, it is up to systems like Northwell to drive this change, to drive this vision of much better care for both their providers and their patients at a much higher level of quality at much lower cost, and accommodate the transitions in revenue models that have to happen, and they have to be cleverly and carefully managed because they can't show lack of profitability or declining profitability. But it has to be a proactive decision by systems like Northwell. So that's why I urge this audience to look at how to make these transitions. The current innovations groups are not cutting it.
Vinod Khosla, thank you so much for taking the time.
Thank you.